Hello students, good evening. Welcome to ENT Thursdays. Am I audible? Can you hear me? Hello students, good evening. Welcome to ENT Thursdays. Can you see me? Can you hear me? Delay कम कर दिया. So I had asked for your suggestions for ENT Thursdays, what should be the topics, and many of you suggested that you wanted it in the form of a clinical discussion because we have already done the topics very beautifully in Marrow, and we have done so many MCQs and we keep doing MCQs. So you wanted something like a clinical discussion. So we have done this in the neck infections in the form of clinical discussion, and we have added a little bit of instruments also, whatever is required, whatever is necessary, whatever is in this can fit in this set. So again, welcome to ENT Thursdays, and that is for your benefit, for opening your minds to endless possibilities. So I hope it will benefit you, and your minds will uh, open, and you will be able to answer any question in your exam, and treat any patient, come to a diagnosis and treat any patient very beautifully, right? Okay, so we will start with the first question, and the first case. And the first case is a 48-year-old diabetic male who came to the OPD with the complaint of pain and difficulty in swallowing since 3 days after he had chicken for lunch, which he was eating in a hurry as he had to attend a meeting. So he has, so again, looking back, what is his complaint? What are the important things here? Okay, wait, yes. Okay, so he is a 48-year diabetic, and he right now has difficulty in swallowing and pain in swallowing. So what is pain in swallowing known as? Pain during swallowing is, yes, it is known as odynophagia. Difficulty in swallowing is dysphagia. So he's been having this complaint since 3 days after he had, and all this started after he had chicken for lunch, and that he ate hurriedly. He has also developed fever for the past 2 days, for which he is taking crocin, but no benefit now. On examination, his temperature is 102. There is tenderness over the neck, the tonsils are appearing mildly congested, and on indirect laryngoscopy, there is pooling of saliva in the pyriform fossa. So what is his most likely diagnosis? So what do you think is the most likely diagnosis of this patient? He is having, right now he is having uh, odynophagia, he is having difficulty in swallowing, painful swallowing. Along with that, he has fever, very very important, he has fever, his temperature is high, there is tenderness over the neck, and everything has started after he has had chicken 3 days back. So what is the likely diagnosis? Can it be pharyngotonsillitis? Can it be pharyngotonsillitis? Okay, so I can see all of you are already started answering, and yes, I want more answers to come in before I answer this. Okay, yes, so all of you say that this is a foreign body esophagus. So why do you say that this is foreign body esophagus? There is mild congestion of the tonsil also. Tonsils also mildly congested. So can it not be a pharyngotonsillitis? Can it not be a peritonsillar abscess? or peritonsillar abscess ultimately leading to a parapharyngeal abscess, a tonsillar infection ultimately leading to a parapharyngeal abscess. What here in the question tells you that this is foreign body of the esophagus? What here is telling you? What's the key point here? Yes, I can also see somebody saying, Sameer is also saying that this is a retropharyngeal abscess. So there are so many differential diagnoses that you are having in mind. You say that this is, if you say that this is foreign body of the esophagus, what is the important thing that is given in the question that tells you that this is foreign body esophagus and this is not rest of the following? Even if there is congestion of the tonsil, this is not pharyngotonsillitis, this is not peritonsillar abscess. Yes. Yes, very good. Jay says there is pooling of saliva. Excellent. Pooling of saliva. This is the, yes, very important finding. Pooling of saliva in the piriform fossa. How does it appear like? Yes, it appears something like this. This was the picture that was given in AIMS this 2020 and was marked. These areas were marked and was asked what are these areas. Yes, so this is the two piriform fossas. We can see that there is pooling of saliva in the piriform fossa, and excellent. I can see Rohit answering. Rohit says that this is Jackson sign. Excellent. This is what is known as the Jackson sign. Jackson. Have you heard this name somewhere else also? Jackson. What is Jackson? Have you heard of Chevalier Jackson? Yes, the person who discovered did a lot of work on bronchoscopy, discovered the position of bronchoscopy, because of which the position of bronchoscopy is also known as, yes, I'm waiting for you. Yes, yes, Chevalier Jackson position, or it is known as barking dog position or sniffing the morning air position. So we can see that there is pooling of secretions. So what does this pooling of secretions signify? The pooling of secretions signifies that even the saliva is not able to go down into the esophagus, which means that there is something obstruction in the esophagus. That can be either in a foreign body of the esophagus, that can also be very, very important in malignancies. Yes, that can be present in malignancies of the hypopharynx also, or in malignancies of the esophagus also. That is what is the important feature that you will see only either in malignancy or you will see in foreign body of the esophagus. So that is why pharyngotonsillitis, peritonsillar abscess, parapharyngeal abscess, all these are ruled out. Retropharyngeal abscess is ruled out. Now what is angioedema? Yes, have you heard of angioneuritic edema or angioedema? Yes, this is the edema of the subcutaneous tissue of the dermis, and that most of the time is idiopathic, but that can appear because of very commonly because of hypersensitivity. And how does that appear like? Can it not lead to pooling of secretions? Does it not involve the esophagus? That can be either, yes, that can be uh, either, yes, just have a look here. Manthan, I will just come to your question. Yes, before that, just have a look here. This is how the angioedema looks like. It can be localized as you are seeing here in the lower lip or here in the upper lip. It can follow trauma. It can follow hypersensitivity. Here we can see of the tongue. So whenever you see that the floor of mouth is raised or the tongue is swollen, so don't immediately come to the conclusion that that is Ludwig's angina. See what is given, what the presentation is given. In Ludwig's angina, there is submandibular, all this area is also tense and swollen. So if there is only the tongue is edematous, whereas there is no tense brawny induration of the submental or submandibular area, then you cannot say that that is Ludwig's angina. Just see here, it can also be localized to the hands. It can be complete face. It can complete the cover the complete face, the eyes, the face, cheeks, lips. And just see here, just see this picture here, which is marked as A. Yes, can you see that this in this patient the angioneuritic edema is involving the uvula? Yes, so this only edema of the angioneuritic edema that involves the uvula is what is known as, anybody? Yes, can you tell me it is known as what? Yes, it is known as, very good, this is known as Quincke's disease. Again, that is a question of your exams. Quincke's disease. Quincke's is localized edema of the uvula, and this very, very commonly follows either hypersensitivity or following any surgery. Why surgery? Yes, because of, anybody? Yes, because of trauma during intubation. So angiolytic edema can also occur following trauma. So yes, now we come back. So we can see that this in angiolytic edema there is no fever. Angiolytic edema is a sudden onset edema leading to sudden swelling. If it is in the larynx, it can lead to stridor. It can lead to, if it is in the tongue, it can lead to difficulty in swallowing, but it does not involve the esophagus. It does not involve the esophagus, so pooling of saliva will not be seen in angioedema. Now, yes, I can see somebody asked me that why is there fever? So probably there is, because of the foreign body, there is some laceration which is leading to some infection, and there is fever. So anyway, we have diagnosed that this is a foreign body esophagus. Let us see what this question asks next. Okay, so what investigation will you get done for this patient? So what is in your mind is you have come to a conclusion that this is not pharyngotonsillitis, this is not peritonsillar parapharyngeal abscess. You have it in your mind that most likely this is a foreign body, the esophagus. So what is the investigation that you want to want for this patient next? Will you get a complete blood count done? Will you get a blood sugar done? This patient, I suppose in the question was given that he is a diabetic. Was it given? Yes, this is a diabetic male. This is a diabetic male and he also has fever right now. Yes. So, do you want to get a complete blood count done? Do you want to get a blood sugar done? Do you want to get a X-ray of the STN done? Or should you get all of these done? What do you think? X-ray definitely, but did you notice something in the question that there was fever also? This patient also had fever. So will you not like to investigate that why this patient has fever? Does this patient have some infection going on because of the foreign body or some other pathology because of which he has fever? So is it inflammatory infective pathology because of which the patient has fever? So yes, very important is we need to get a complete blood count also done. This is a diabetic patient. We need to get his blood sugar done. We need to get a X-ray soft tissue neck done. So we will get, yes Subham, yes we will get, yes Fazal, yes Ayush, we will get all these three things done. So here you are approaching, this is not a MCQ where you have to mark a single choice. This is how you're going to approach a patient. So you have to imagine yourself sitting in the OPD and this is the patient who has come to you. Just imagine a 50 years old with this presentation. So what comes to your mind is, okay, this patient has a foreign body but he has fever, so you need to investigate. So how you're going to think as a clinician, how you're going to what all will come to your mind. This is what we do whenever we do a case discussion. So okay, so you will get all these three things done. So fine, good, very nice, we got everything done. And let us see, his test showed that the TLC was raised, it was 15,000. The random blood sugar was 200. So what should the normal blood sugar be normally? Fasting should be, all of you? Yes, fasting blood sugar should be, yes, less than 100. And the PP blood sugar should be less than 140. So his diabetes is, sugar is not controlled properly, TLC is high, and the soft tissue neck also you have got done. And what you can see in the soft tissue neck, just see carefully, can you see something in the soft tissue neck? We can see here this airway is good, the epiglottis seems good, it is appearing like a leaf shaped epiglottis, that is appearing good. Anything you are seeing? Yes, are you seeing something in the X-ray? What are you seeing in the X-ray? Can you see this marked? Yes, we are seeing this foreign body. And can you make out by the X-ray that this foreign body that you are seeing here is in the larynx or it is in the esophagus? How can you make out that this that you are seeing is not in the esophagus? This is in the esophagus, this is not in the larynx. How can you make out? Yes, now just see here. This is the airway, this is the airway, this is the larynx. So this is the airway of the larynx, is the trachea. Can you make out? Yes. And this behind it is the esophagus. Behind the trachea, behind the larynx is the esophagus. So this foreign body is impacted in the esophagus. This is not in the airway. So the air we can see, that is the larynx. Okay, so we are seeing the foreign body. Wonderful. So what we diagnosed was correct. So what should be the next step of management? And the test have also shown that he has infection. Okay, so what should be the next step for the management? What will you do? How are you going to manage? The patient came to you with some complaint, and you could diagnose by the history itself that this is probably a foreign body, which has got lodged in the esophagus, and you confirmed it by x-ray. What are you going to do? What are you going to do? Did you see the x-ray properly? Did you see this foreign body here? Can you see this whitish structure here? Yes, just see here, which is marked by the arrow. This thing, this is what is the foreign body. So now I remove this ink, and you will be able to see it clearly if you have not seen it earlier. See it carefully. This is what you get in your exams, the foreign body x-ray. Yes. So what are you going to do? Are you going to do conservative first? Are you going to do conservative first, or there is a foreign body which has got lodged in the esophagus? Do you think it is ever going to come out by itself? No. The patient, yes, we will have to, you will start antibiotics before surgery. Like ultimately what we have to do? Yes, Chaitanya says that we will start antibiotic. What is the main management for this patient? Yes, we will have to remove this foreign body. This foreign body which has got impacted into the esophagus needs to be removed. You will have to remove it. So how are you going to remove this? Yes, very good. You will remove it endoscopically. So when you have to, okay, Surat says that first control the fever and sugar. So what if the fever is because of the foreign body, because of the foreign body causing a laceration, there an infection there? So unless and until you remove the foreign body, how are you going to control the fever, the infection? Yes, so first we are going to, yes, you can start the patient on antibiotics because the TLC is very high. So we have already started the patient on antibiotic. Very good. Now we are going to remove it. Yes, endoscopic. What endoscope will you prefer? Will you prefer a rigid endoscope or a flexible endoscope? Again, a question of your exams. Rigid or a flexible endoscope? Yes, whenever we have to remove a foreign body, we go for a rigid endoscopy, rigid esophagoscopy, not a flexible endoscopy. Flexible endoscopy can be used to visualize the esophagus or any pathology. By flexible endoscopy, you can find out that there is a foreign body, but to remove it, we will have to go for rigid endoscopy. Okay, so which of the following scopes should you use for the procedure? So yes, look at these two scopes that we have. This is the scope 1 and this is the scope 2. So yes, this answer I want you to tell me a very important question. This is, which scope are you going to use here? The 1 or the 2, and what's the difference between 1 and 2? Yes, let me see what you tell me, whether it is 1 that we are going to use or we are going to use 2. Yes, 1 or 2. I'm waiting for your answers. Yes, will you use 1 or 2? What is the difference between 1 or 2? One of them is a esophagoscope, the other is a bronchoscope. So tell me which one is a esophagoscope, which one is a bronchoscope. Yes, I can see all of you are giving me the correct answer. We are going to use 2. One is a bronchoscope. So how do you differentiate between a bronchoscope and a esophagoscope? Are you seeing some difference that is clearly visible in 1 and 2? In 2, can you see that there are certain markings? There is marking 15. There is marking 20, 25. Yes, so there are certain markings in the 2, whereas in 1 there are no markings, but in 2 you can see some openings. Can you see some openings here? Some bends. Yes, so 2 is a esophagoscope, whereas 1 is a bronchoscope. Why are there markings on the esophagoscope? Why do you have markings on the esophagoscope? Yes, so that we can find out how deep we have gone. In the esophagus, there are constrictions at certain areas. So the first constriction comes at the pharyngoesophageal junction. That is the upper that is the upper esophagus, where the pharynx starts. where the pharynx ends and the esophagus starts, that is the upper sphincter of the esophagus, and this is at 15 centimeters. Next is at the arch of aorta, and that is at 25 centimeters. And next is where it enters the diaphragm to enter the stomach. This is at 40 centimeters. So this is at 15 centimeters from the incisor, from the central incisor. So that at these areas of constriction, you have to be very careful. You have to wait. You don't have to force the esophagoscope into the esophagus, otherwise there will be perforation. So that is why the esophagoscope has constrictions, whereas bronchoscope does not have any constriction. Wonderful. Why do we have vents in the bronchoscope then? Why are there openings in the bronchoscope? Okay, so whenever we are doing bronchoscopy, we are accessing, we are putting the bronchoscope into the larynx and into the trachea. So if we are putting this big bronchoscope into the larynx and trachea, where will we put the endotracheal tube? How will we intubate the patient? And if we do not intubate the patient, how are we going to perform this procedure under general anesthesia? So that is why bronchoscope has vents. It has vents on both the sides. This we are seeing on one side, it has on both the sides, so that both the lungs can be ventilated at the same time. And this is for oxygenation of the patient, so that we can do oxygenation, general anesthesia, as well as the procedure at the same time. So yes, in this patient we are going to use two. So that was wonderful. So now a 2 centimeter chicken bone was found impacted. So we have done a esophagoscopy for this patient. A rigid esophagus on the rigid esophagoscopy was a 2 centimeter chicken bone was found impacted at 16 centimeters. So 16 centimeters means 16 centimeters is, yes, 15 centimeters is the cricopharyngeal junction. So just below that is this impacted. And if I may ask you, what is the most common site of impaction of any foreign body in the esophagus? Is it at the above the cricopharyngeal junction, that is above the esophageal sphincter, at the cricopharyngeal sphincter, or below just immediately below the cricopharyngeal sphincter, mid esophagus, or at the cardiac sphincter? So what do you think is the answer? Yes, the most common site is just below. Yes, contrary to what you think, you might think that the most common site is above the cricopharyngeal sphincter or at the sphincter. No, it is just below. It is just below the cricopharyngeal sphincter, because the function of the hypopharynx is to push the foot down. So when the foot is in the hypopharynx, the hypopharynx constricts to push the foot down through the cricopharyngeal sphincter. So the tone of the muscles above the cricopharyngeal sphincter is very good, whereas tone of the muscles just below the cricopharyngeal sphincter is very poor, because the moment the foot comes down, this area has to relax. So this is the area where most commonly any foreign body gets lodged, that is just below the cricopharyngeal sphincter, and that is exactly where it has got lodged, 16 centimeters, at 16 centimeters, and it was removed. Okay, so we could remove it. However, he continued to have spiking temperatures. The tenderness in the neck anodinophagia persisted. He also developed neck stiffness, difficulty in neck movements. His temperature was now 103 degree Fahrenheit, and the repeat CBC, complete blood count, showed a TLC. TLC previously was 15. Now it has gone up to 19,000. C-reactive protein is 25. What can be the differential diagnosis? C-reactive protein. What is C-reactive protein an indicator of? C-reactive protein is indicator of, yes, it is an inflammatory marker, acute inflammation marker, and this is more sensitive than ESR. So it is, how much is normal C-reactive protein? Yes, usually from 0 to 10. Less than 10 is considered as normal. Here it is raised. It is so much raised. And always remember in your clinical practice, C-reactive protein is a more important marker of inflammation than ESR. So you can use it wherever you want to see that there is some inflammation taking place somewhere. So now what do you think is the differential diagnosis? Yes. Yes, I can see you have your. What do you think? Can it be a foreign body? Second foreign body? Maybe you remove that foreign body and you were so happy that you removed that foreign body, you forgot to inspect the rest of the esophagus. Can it be meningitis? Why at all meningitis is given here? Because there is neck stiffness. Neck stiffness, can alone neck stiffness diagnose that patient to be meningitis? No. In meningitis also there are other features like there is headache. Yes, the fever is there in this patient also. There is neck stiffness, but there is headache, there is altered sensorium, retropharyngeal abscess, mediastinitis, esophageal perforation, peritonsillar abscess. So, what all can be the differential diagnosis? Yes, I can see all of you, Ratandeep, Swati, Amutha, Suraj. Everybody is telling me that this can be a retropharyngeal abscess. Okay, now just open your minds. Okay, keep your mind just open. The patient, you removed something, the foreign body, that was a chicken bone that was impacted in the esophagus. You removed it. Okay, so following removal, also the patient's fever has not subsided. The patient has high peak of fever. The patient also has tenderness in the neck. Odynophagia is also difficulty in swallowing. Painful swallowing is also persisting. So yes, very nice. There can be one TD that there is a retropharyngeal abscess here. Can there also be mediastinitis? You have done an esophagoscopy. Can there be esophageal perforation? What is the most common cause of esophageal perforation? Yes, it is iatrogenic. It is following endoscopic procedures. So can it not be a esophageal perforation which has led to a mediastinitis, following which the patient has again a spiking peaks of temperature? Can it be? Yes or no? Can be. So these are all the differential diagnoses that comes to our mind, that maybe we did a endoscopy, we did a esophagoscopy, rigid esophagoscopy, maybe we injured the esophagus, following which the patient developed mediastinitis. So now you are in a panicky situation. Following removal, you were thinking that the patient will be fine, and you are very happy once you saw that bone that came out and that you removed. But now you're very panicky. You can see that the patient situation is deteriorating. So these are the things that comes to your mind, that can be esophageal perforation, that can be mediastinitis. And again, what comes to your mind is that this patient was having fever initially also. So is it possible that this patient was in the process of developing a retropharyngeal abscess? So now you will answer this, that what is the most common cause of acute retropharyngeal abscess in children? In children. Yes. Yes, I'm waiting for your answer. Yes, acute retropharyngeal abscess in children. The most common cause is inflammation of the retropharyngeal neck nodes, retropharyngeal group of nodes, of lymph nodes. What are those known as? They are known as, yes, I'm waiting for your answer, nodes of Rouvier. Yes. So, whereas in adults, what is the most common cause of acute retropharyngeal abscess? Acute retropharyngeal abscess, most common causes in adults is, yes, yes, I'm waiting for your answer. Yes, in adults, the most common cause of acute retropharyngeal abscess is a trauma. It is trauma. It is very commonly a fish bone. It can be external trauma. It can be a chicken bone. It is trauma to the posterior wall of the esophagus. Yes, it is traumatic. So, yes, I can see all of you are answering. TB spine. Divya says TB spine. TB spine is the most common cause of chronic retropharyngeal abscess. That is not acute. Okay, so get it corrected. The chronic retropharyngeal abscess, if the patient is just presented with a chronic retropharyngeal abscess, what would have come to our mind first was TB. But this is an acute retropharyngeal abscess that the patient is presented with high peak of fever, and that too following a foreign body ingestion, foreign body lodgement. So yes, the most common cause is injury, trauma. So we have all these things in our mind, and now we want to confirm the patient is deteriorating, and all the onus is on you to immediately find out you did the procedure under GA and still the patient is deteriorating. So next best investigation for this patient should be, what should be the next best investigation for this patient? Yes, what should you get done? You want to rule out whether it is a esophageal perforation or it is a mediastinitis, or you want to, or this is a retropharyngeal abscess. So what investigation will you get done? Yes, you are the surgeon there, you are the treating consultant there. The patient is asking you, डॉक्टर साहब you told me कि ये फंसा हुआ है, चिकन बोन फंस गया है, आपने मुझे दिखाया निकाल के कि this was the cause of all that, it was the culprit, but see my patient is deteriorating. तो क्या करोगे? एमआरआई करोगे, एक्सरे करोगे? इम्तियाज सेज इट इज एक्सरे, जे सेज इट इज एमआरआई, क्या करेंगे? व्हाट डू वी हैव टू सी? Yes, CT scan. What do we do? Yes, we will get a CT scan done. And CT scan and the CT scan in this patient can also detect the leak. By chance there is a esophageal perforation. What we do in the CT scan is we put a dye 20 minutes before doing the CT scan. We put a dye, and can this dye be a barium? Can this dye be barium? Not at all, because we are suspecting perforation. If we are suspecting perforation, we know that barium, if it leaks out of the perforation, it can lead to severe reactions, it can lead to mediastinitis. That is what we do not want. So we will put a water soluble contrast just before doing the CT scan, and we will do the CT scan. And okay, we did the CT scan here, and the CT scan is given here. What should be the further management? So the CT scan is given here. What are you seeing on the CT scan? Yes, we are seeing this is the airway here, this is the esophagus. No, this is the larynx. This is the airway. So this is the larynx. Where is the esophagus? It has got compressed here behind. Yes, can you see something here in the CT scan? Can you see a hypodense area here all? Can you see that the prevertebral shadow is increased? Yes, the prevertebral shadow is increased here. So how much increase of prevertebral shadow is significant? Again, that's a question of your exam. Yes, yes, I told you the topic beforehand so that you can come prepared. So you're quickly going to tell me, at the level of C2, what is the normal retropharyngeal space thickness? Yes, very good, Sneha. Yes, Imtiaz. Yes, Pinky. What is this at C2? What is the normal retropharyngeal space? How much? How much is the normal retropharyngeal space? At C2 it is? Yes, I'm waiting for your answer. At C2, at C2, okay, to two-third of the vertebrae, more than two-third of the vertebrae. Okay, we are measuring in millimeters. At C2, 7 millimeters. Very good. Yes, very good, Nivedita. Very good, Suraj. Pragati. At C2 is 7 millimeters, and at C7, C6, C6, it is either, yes, in children 14 millimeters, and in adults it is more than 21 millimeters. Yes, so that is considered as normal. That is considered as normal. So, by the CT scan we have confirmed that this is a retropharyngeal abscess. So this patient who came to you actually with a foreign body was, now you have the answer that why this patient was having fever initially, because he was already in the process of developing a retropharyngeal abscess, and which has now progressed. And now what should be the management? What should be his further management? So we first remove the foreign body, patient's conditions deteriorated, and yes, now you are seeing on CT that this is thankfully not a perforation. This is thankfully not a mediastinitis. In mediastinitis, you will see the abscess, you will see pneumothorax. Air has leaked into the mediastinum. You will see, you can see pleural effusion. You can see there will be very severe pain in the chest that the patient will complain. In esophageal perforation following surgery, one important symptom that the patient complains of is very severe pain radiating to the back. Yes, that is esophageal perforation. So yes, very good. We will go for incision and drainage, and we will give the IV antibiotics that we were giving. Now will now you have to actually cover the retropharyngeal. Here we give the cover of gram positive, gram negative, as well as anaerobes. Very important. You will have to add metronidazole here along with the gram positive and gram negative cover, and you will drain it. Yes, you will drain it again. You will have to drain it. You are going to drain it under general anesthesia. Very careful. Ultimately, yes. So uh, events come to us, and yes, Ramesh, for ruling out retropharyngeal abscess, yes, of course, we can do a CT scan initially for ruling out a retropharyngeal abscess. When the patient has come with fever, we could have done a CT scan initially also, but there is also possibility that initially the retropharyngeal abscess might not had developed. Many a times it develops, there is just a little cellulitis or edema of the retropharyngeal space, which you might think might just recover because of the IV antibiotics. But yes, if we would have got a CT scan done initially, and if we would have seen the edema of the retropharyngeal space, the thickness of the prevertebral shadow increased, we would have given a better IV cover. We would have given a more stringent, a more high cover of the antibiotics prevented that could have prevented this. That could have prevented this. Can you hear me now? Can you hear me? Yes, I can see your message saying that it is I'm not audible. I'm not audible. Can you hear me now? Am I audible? Yes, can you hear me now? It's clear now? Okay. Okay, so it is clear now, so then we can just go ahead. Yes, you can hear me. Okay, so do you want me to repeat something? Do you want me to repeat something? Yes, in one of the classes, one of you told me that I was shouting, and I actually realized that I was shouting. So, can you hear me now? Do you want me to repeat something? What I told you was that we could have done a CT scan initially also when the patient had fever. Because the patient had fever, we could have done a CT scan initially also. And if that showed the prevertebral shadow was increased, that suggested that this patient was developing a retropharyngeal abscess, we could have given him a more stringent cover of the antibiotic. We would have given him added anaerobic cover also. We would have given him a more higher dose of the antibiotic, which could have prevented this complication to occur. So is that clear to you, all of you? So can we go to the next? Yes. Now here like all of you asked me to include the x-rays also and some foreign bodies also, and separately doing it, maybe not many of you wanted, so I have thought of putting this the foreign body along with the instruments when we do the cases itself together. So here we can see that there is a round structure in the x-ray of this patient. Yes, so this is an x-ray that is asked very commonly in your exam. The x-ray is given, and what is asked from you is that this is a foreign body. Yes, you can make out that this foreign body is a it is a coin. The most common foreign body of the esophagus is a coin. So we can see that this is a coin. So what you need to tell me is that this coin has got stuck in the esophagus, or is it in the larynx? This is in the larynx, or is it in the esophagus? This coin is in the larynx or in the esophagus? I it is in, do you want yes pakka esophagus I can or it is uh, not audible now. Is it audible? Am I audible now? Am I audible now? Yes. So is it in the esophagus or is it again? Is it not audible? Audio problem? Audio problem again? Can you hear me now? Can you hear me now? Can you hear me now? Yes, you can hear me now. Okay, so yes. Yes, now tell me whether this is in the esophagus or it is in the larynx. So we saw it, this is, yes, this is esophagus or the larynx. Now this is the AP view and this is the lateral view. This is the lateral view. So this is esophagus or larynx. And now I'm going to show another picture. This is again the AP view and this is now the lateral view. Yes, so which one is esophagus and which one is the larynx? Yes, so this, as you told me correctly, this was esophagus. Why is this esophagus? Because in the esophagus, the largest diameter of the esophagus is, yes, it is the horizontal transverse diameter. In the esophagus, the largest diameter is the transverse diameter, whereas in the larynx, the largest diameter is in between the vocal cord. That is the AP. Yes. So that is why when you in the esophagus, the coin gets stuck. It looks like this, and when we are seeing laterally, we can see a rim. We can see the rim like this. whereas since in the larynx the largest diameter is the AP diameter, so coin gets stuck like this. So when you see from here AP, you see a rim like this, and if you see the lateral view, you see it like this. Yes, so excellent. That is how we differentiate whether it is in the esophagus or it is in the larynx. So we have the next question here. Okay, so the next case we have here is a 30-year-old man presented with a complaint of fever since 4 days. There is inability to open the mouth completely. There is inability to open the mouth completely. What is inability to open the mouth completely known as? Inability to open the mouth completely. Yes, that is okay. Swati, what was not audible? The X. Yes, very good. I can also see. Yes, wonderful. I can see a very nice thing that somebody has written. Yes, that because yes, Subham writes that this coin, this foreign body that we are seeing, this coin, you can see it is in the airway. Can you see the air above it and below it? That shows that this is in the airway. Wonderful, very nice. Yes, this is lower down, so here you cannot make the airway. You cannot make, yes. So here, yes, so that is what is known as mouth inability to open the mouth completely. That is what is known as trismus. There is odynophagia since 2 days, and there is difficulty in speaking and drooling of saliva for 1 day now. Since morning he has difficulty in breathing, which increases on lying down. He is a smoker. He also gives a history of chewing tobacco. On examination, he appears dehydrated. Temperature is 102. Respiratory rate is 25 per minute. So he is febrile. Respiratory rate is high. There is a bad smell coming from his mouth. Mouth opening is only 1 centimeter. Mouth opening is only 1 centimeter. What is the normal mouth opening? How much is the normal mouth opening? Yes, normal mouth opening is 3 centimeters, is 5 centimeters. 5 centimeters is normal mouth opening, and when we compare it with fingers, we say that we are able to put 3 fingers into the mouth. That is what is normal mouth opening. So here it is now restricted only to 1 centimeters. The tongue is elevated. So there is a diffuse swelling in the upper neck, which was tender on palpation. So neck movements were painful and restricted. What is your most likely diagnosis? So what is your diagnosis here? So what are the important key points that are noted here? Yes, what are the key points that we need to note here? That the patient has fever, so it is probably an infective condition. Inability to, there is trismus, there is odynophagia, there is difficulty in speaking, drooling of saliva. Drooling of saliva is because of, yes. So I can see that you are telling me Ludwig's angina. Can it not be epiglottitis? There is drooling of saliva. Yes, there is bad smell coming from the mouth. There is trismus. Yes, in epiglottitis, trismus is not there. So, tongue is not elevated. The neck is normal in epiglottitis. This cannot be epiglottitis. Yes, all these things, the tongue is elevated. There is trismus. Trismus, odynophagia, fever, all that can be present in peritonsil abscess and parapharyngeal abscess also. Whereas the tongue is elevated, there is tenderness on palpation of the neck, swelling in the upper neck, all the neck movements are painful. All this tell you that this is, yes, Ludwig's angina. Very good. So you have diagnosed this patient as Ludwig's angina. Okay, so which investigations will you get in this patient? Which investigations will you get done in this patient? Complete hemogram, blood sugar, orthopentogram which is known as OPG, and CT of the neck. So you are more or less definite that this is a patient of Ludwig's angina. What investigation will you get done? Yes, tell me what all investigation will you get done? Will you get a complete hemogram done? A blood sugar done? Yes, we will get a CT scan done. Now this is not MCQ. You are approaching this case. This is a case that is presented to you, and he has come to you in the emergency. There's difficulty in swallowing. You can see right now he is difficulty in breathing also. What all investigation will you get done? Will you get done only CT scan? No, very good. Yes. J, yes, very good. We get done complete hemogram. This has to be done. The patient has fever. We need to get a complete hemogram done. Blood sugar has to be done. OPG, what is OPG? CT scan needs to be done. Yes, CT scan needs to be done. All needs to be done. What is OPG? What is orthopentogram? Have you ever seen an orthopentogram done? Have you ever seen any patient with orthopentogram? Have you ever got any dental procedure done? If you've got any dental procedure done, then yes, just see here. This is what orthopentogram looks like. It is the panoramic view of the complete teeth. So what we can see here, can you see this here? Hypodense area at the root. So this is what is known as periapical abscess. So when we see it carefully here, we can see here is the caries here. Again a hypodense area, and here there is a periapical abscess. So yes, orthopentogram. Yes, and if I ask you what is the most common cause of neck space infections? Previously it used to be a tonsillar infection. Nowadays, what is the most common, very very important question this is, which is the most common cause of neck space infection? Any neck space infection? Yes, most common cause is a dental origin. Most common cause is infection of the teeth. So we will get all these things done. So we got it done. The CT scan showed multiple loculations in bilateral submandibular and submental spaces. So that confirms that this is a submandibular space infection. There was also edema in the lateral pharyngeal space. What is lateral pharyngeal space known as? Lateral pharyngeal space is known as parapharyngeal. Yes, Suvam asked me what is the cause of drooling of saliva. What is the cause of drooling of saliva? Drooling of saliva means that the patient is not able to swallow the saliva also. Have you seen any picture of a Ludwig's angina? The floor of the mouth is raised so much, the tongue is raised up, because of which the movement of a tongue is totally restricted, because of which the patient is not able to speak. The patient is not able to swallow. The patient is not able to swallow the saliva also because the tongue is raised up. The floor of mouth is so swollen. So he keeps on spitting the saliva outside. So that is the cause of drooling of saliva. So is it a parapharyngeal space abscess? Yes, lateral pharyngeal space is known as parapharyngeal space. Yes, so what we can see is that this is a Ludwig's angina. It is going into the parapharyngeal space also. Can it happen? Yes, the most common space infection is parapharyngeal space because it can have infection from everywhere, from all around. So it can have infection coming from retropharyngeal, from cervical, from submandibular, from tonsil, from everywhere infection can come here. So that is the most common. OPG shows periapical radiolucencies that we just saw in the OPG. So we have confirmed that this is a Ludwig's angina. What should be the order of management? So what do you do? What should be the order? Will you start the IV antibiotics first? Will you go for securing the airway first? Why the question of securing the airway also comes here? Yes, this is a patient who is now into respiratory distress. Did you read the question properly? What was mentioned was that this patient right now has a yes, since morning he has difficulty in breathing and which is increasing on lying down. So this patient is not even able to lie down. The moment he lies down, because of gravity, everything falls down because of the swelling there. He has compression of the neck, and he has right now he is having difficulty in breathing. So yes, 2314. What is the first? Yes, we know what is the order of management is always ABC. Airway, breathing, circulation. So the first always secure the airway. So this has to be first. So 2 comes first. Next is, yes, you get the IV fluid. 1. Next is, yes, drain the abscess, and next is management of the infected tooth. Management of the, okay, drain the abscess and management of the infected tooth. Now in the previous case that we saw, that patient was diabetic. Yes, so we saw that this patient progressed to a retropharyngeal abscess following extraction of the foreign body. So very, very important is management of the diabetic status there, management of the sugar there. Otherwise the patient is not going to recover. Probably because of all these things, the patient, even if his foreign body was removed, he went into a retropharyngeal abscess. So here we have to manage the infected tooth also. So now we know that the odontogenic abscesses are the most common cause. Odontogenic cause, dental cause, is the most common cause of neck space infection. Neck space infections are so life threatening. They are those so severe. So always remember that you have to take good care of your teeth. Okay, so how should the airway be secured? So you told me that we will need to secure the airway. So how are we going to secure the airway of this patient? Will you like to go for orotracheal intubation, or will you go for a tracheostomy? Yes, will you go for an intubation or a tracheostomy? And this intubation is orotracheal intubation is what is given here. Will you go for orotracheal intubation, or will you go for a tracheostomy in this patient? This is a Ludwig's angina. Swati says tracheostomy. Why not orotracheal intubation? Yes, we know for intubation what was mentioned in the question. How much was the mouth opening? The mouth opening was only 1 centimeter. The neck movements were restricted. There is so much of swelling. The tongue was raised. So orotracheal intubation will not be possible here. We will have to go for a tracheostomy. Yes, we will have to go for a tracheostomy in this patient. So, had there been a choice which said fiber optic nasotracheal intubation, then that could have been done. Nowadays, fiber optic nasotracheal intubation, what is done in that is a fiber optic endoscope is passed. A fiber optic flexible endoscope is passed through the nose, and the endotracheal tube is mounted on the endoscope from before itself. And once it reaches the trachea, the endoscope is withdrawn, and the endotracheal tube stays there. So that could have been an option, but that is not here. That has to be done with very experienced hands, because here the patient is already in distress. The moment you will make him lie down, he will go further into distress. So you will go for a tracheostomy. Okay, so excellent. We will go for a tracheostomy. Which of the following tubes will you use for tracheostomy? So will you go for the first tube that is shown here, or will you go for the second tube? So what we can see here is that the first tube that is shown here, yes, I told you that it is better we will include the instruments that are important for us here itself. So yes, this is the first. This we can see is a metallic tube. This is a metal tube. This is a Portex tube. What do you want to do here for the patient? Will you like to go for a metal tube, or will you like to go for a Portex tube when you do tracheostomy? Yes? Yes, a Portex tube. Why not a metal tube? Why not a metal tube? Yes, you told me it is Portex. You are absolutely 100% correct. Why not a metal tube? Because can you see that a metal tube does not have any cuff? There is a cuff here. And whenever we are doing the tracheostomy, initially we always want the cuff so that the hemorrhage, the blood, the secretions do not get aspirated. So a cuff is necessary, otherwise this will get aspirated. What is the significance of a metal tube? When do we use metal tube? A metal tube was used. Nowadays we do not use metal tubes, but metal tube was what was used initially. Previously metal tubes used to be used for what significance or what purpose? Now just see here. This is the outer tube. This is the outer tube, this is the inner tube. Can you make out that this inner tube is longer than the outer tube? So this inner tube is put inside here and it comes. So for cleaning the tube, once the patient just needs to take out the inner tube, clean the tube and again replace it. So the outer tube stays in place, so there is no question that while putting the tube might get dislodged. The patient relatives do not feel scared that once they remove the tube, what if they are not able to put it again. So previously when we used to send the patients back after with tracheostomy tube, when we used to send them home with tracheostomy tube, it was always preferred to give them a metallic tube, but the metallic tube led to corrosion of the tracheal walls. That is why it is not very commonly used. Nowadays what is used is a Portex tube. The Portex tube, when we do any surgery, the Portex tube with cuff is used, and when we send the patient home, we give him without cuff. So this tracheostomy tube, the metal tube, is one that is asked in your exam. The cuff tube is also asked. The cuff tube is another thing that you need to know here is that this is a low pressure. This is a low pressure high volume tube. This is a low pressure high volume tube, and this metal tube is what is known. This metal tube is again Jackson's tube. So we have so many Jacksons, no? Whereas we have another metal tube. This is what is known as a Fuller's tube. Fuller's tube. Now what is the difference? Can you see the Fuller's tube? Yes, here also Jackson. So we can see Jackson is very important. Chevalier Jackson did a lot of work in the larynx. So many things named with Jackson. Yes, we can see that the Fuller's tube is bivalved. It has an opening here in the center, in which this is the outer tube. This is the inner tube. This is the inner tube. So the inner tube will fit inside. What is the significance of Fuller's tube over the Jackson's tube? Yes, it has opening like this. So this can be used when the patient talks for speech. If we want to give the patient speech also, so what will happen is that there is an opening in the inner tube. So when the patient wants to speak, he will keep a finger at the outer tube here, and during expiration the air will go through this opening here, through this opening up, vibrating the vocal cords, and patient will be able to produce speech. So when we wanted to give speech to the patient, this Fuller's bivalved metallic tube was used. Whereas nowadays these tubes are not used. Nowadays if we want to give speech to the patient, what we do is that in this Portex tube only we make an opening here. So when the patient wants to speak, he will keep his finger here, and during expiration the air from here through the opening will go into the larynx, into the glottis, vibrating the vocal cord and producing speech. So what we are going to do for this patient is we are first going to secure the airway by a tracheostomy or by a awake
fiber optic uh, nasotracheal intubation. We are going to start IV fluids, we are going to start the patient IV antibiotics, and we are going to drain the abscess. And once the patient is fine, once we discharge him, we are going to ask him to get all his infected tooth managed and to keep dental hygiene. So that is how we are going to approach this patient. So what we read as the MCQs just are not for answering the questions. What is expected out of you now and also in next is that whenever the patient comes, the whole picture should be clear in your mind that this is the presentation, these are the DD that I have in mind, DD, that is differential diagnosis, that I have in mind, and this is how I need to proceed, these investigations I need to get done. And once I have all the reports, I have the clinical history, I have the examination finding and the reports with me, how am I going to manage this patient? So this is what is when you approach a patient like this, when you do questions like this, when there is any presentation, clinical presentation given in your exam, you don't panic. You know that okay, nothing to worry, this is exactly what I read in my theory, but that was in the pattern of a MCQ. So that is what you need to know, and I'm sure you're getting benefited by the book ENT for entrance exams. Yes, do all the MCQs, it is very important. And yes, a very very important thing that I want all of you to listen and I want all of you to practice in your life is that your mind is very powerful. When you fill it with positive thoughts, your life will start to change, your life will start to become positive. Now just if I ask you that just imagine, okay, just for a second, just close your eyes and imagine that I have given you a lemon in your hand. Yes, I have cut the lemon and I have given a lemon to you in your hand. You take the lemon in your mouth, you squeeze the lemon, and yes, you can taste the lemon. Yes, now you tell me, did you start salivating? Did saliva start pouring out of your mouth? I am waiting for your answer. Did you start salivating? Yes or no? Yes, so did you have a lemon in your hand at all? No? Did you have a lemon in your hand? No, you did not have a lemon in your hand. So when you did not have a lemon in your hand, when you told your mind that there was a lemon in your hand, your body started reacting. Your body started, you could change your body, how the body is reacting. Yes, so such a small thought can change your manifestation of the body, your reaction of the body. So when you think of big thoughts, of good positive thoughts, you cannot just imagine how positively your body will react, how positively your everything will react. So don't the best thing is that your mind can control everything. And who can control your mind? You can control your mind. Don't depend upon external factors. Yes, we are hearing of such a sad news nowadays, everywhere in the everywhere, that external media, external everything influence, everything can influence you only if you allow it to influence you. If so, keep your mind strong, believe in yourself, give it positive thoughts all the time, and it will react positively. No matter what everyone says, you believe in yourself. You know that you have to believe only what your mind says. So control your mind. Don't let your mind believe what others have to say about you. You have to believe what you know about yourself, and always know that you are enough. You are capable of doing everything and anything. So yes, and there is, yes, a question. Amutha says, the first priority to be considered in stabilizing a patient, and then we can treat the basic etiology. Yes, very good. That is what we do. We always ABCs first, and then we treat the basic etiology. So I hope that this was beneficial to you, and keep giving your comments and your suggestions, because your suggestions are very important for me, so that I need to know what you need. Accordingly I can give you whatever you need. So have a wonderful week ahead. Next week we are going to have the conditions of the nasopharynx, and I will put in the post also. So have a wonderful time. Believe in yourself. Give yourself positive thoughts every day. Love you all.